history of how these were developed and why cancer was left out, but it was left out, I think, because of the complication. It's even, cancer patients are even removed from the analysis, so that if someone has cancer and has one of these other episodes, they're not part of the analysis here. But I think currently we're looking at updating, and cancer is something that we're looking at, and we're talking to various groups of physicians to help us be able to do that in a way that will make it work, just because of the complication. So to use these analytics, both on the costs and the typical versus the PACS, to evaluate provider quality and efficiency, we want to look at them together. The average costs are adjusted, or should be adjusted, based on the acuity of that provider's patient population, and we can talk a little bit more about that. The PAC rates can be measured, and the PAC rates are one indicator of quality, and they can be measured as the percentage of the dollars that are spent on PACs versus that are spent for the typical episodes, as I've shown here, and we'll show you later on. Or you can look at the percent of patients with one or more PACs, kind of a different indicator. Both have pros and cons to them. The examples that we'll look at are gallbladder surgery, colonoscopy, and diabetes, again, where we had enough volume to make legitimate comparisons across the providers. Some folks have used confidence intervals or maybe other metric standard deviations to account for the low volume of services as needed, so that might be something you want to do. I haven't done that here. And then the external additional quality measures, some of the same things that you're involved in with the PTE and with the other kind of federal measures, can also be considered and should be considered in conjunction maybe with the PACs. So as far as the costs go, and looking at provider differences, the severity adjustment does prove to be critical. The chart here on the left here, we're looking at an example of gallbladder surgery. We're looking at the facilities, the average cost of the facilities. So this is the facility where the gallbladder surgery took place. The costs that are in this orange bar represent all of the costs, the facility costs as well as the surgeon's costs, as well as any related costs that occurred during that 90-day window of time. And you can see that facility A, for example, or facility E, the difference between facility A and facility E is 65%. So a significant difference between an average cost of about $11,000 compared to about $18,000 for the highest facility. These facilities do have differences in the acuity of their patient population, and these are the patients specifically for gallbladder. So the severity index, for example, for facility A. Facility A has a less severe patient population of gallbladder than does facility D, which is higher compared to the benchmark. So when you put this adjustment onto the costs, typically all of the severity adjustment will serve to kind of narrow the variation generally, because you're putting folks on a more apples to apples comparison. More importantly, it also changes the position, the relative ranking of the various facilities. So it is important to do. You can see facility A moved from being the lowest cost to being in the middle, because their costs are raised by that adjustment, the fact that they had a less severe patient population. If you combine the efficiency measure, that cost measure we just looked at, along with the quality measure, here the PAC rate, the percentage of the dollars that are spent on PACs, you can sort of array it here. Along the horizontal axis, we have the severity adjusted episode cost for those same facilities that we just looked at for gallbladder, and the PAC rates, which range from about 4 or 5% up to 13% for the gallbladder surgery. And you can see that provider B, for example, it's easy to see that they are the most efficient and the highest quality. So they have the lowest PAC rate and the lowest cost, close to the cost of provider C. For provider A, they have a higher quality measure, a lower PAC rate than provider C, but a higher cost. So it's important to think about the relative weight that one might give to the cost versus the PAC rate or the quality, and that might change how you think about the relative ranking between A and C. We can look at this same thing, so the severity adjusted average episode costs and the PAC rates. Here we're looking at diabetes, the chronic care measure. Each of these diamonds here represent a provider. In this case, it's not a facility, but it's the provider that the patient has been attributed to. You can create that attribution however you want. In this particular data set, it was created by the provider that had the highest count of evaluation and management visits, where diabetes was the primary ICD-9. And so you can see here, we have some lower cost, low PAC providers, and some higher cost, high PAC. And generally for this, as well as the gallbladder, there's a relationship, a correlation between the PAC rates and the costs. Higher PAC rates resulted in or had higher costs. There are some outliers there. For example, this provider here, had moderate costs, about $7,000, so right about in the middle, but a pretty low PAC rate compared to the others. In fact, the lowest PAC rate among the others. So again, the weight that you give between cost and PAC rates will determine ultimately where that provider might rank in the system. And then for colonoscopy, the distribution here is a little bit flatter. So there's a wide difference in the cost of the colonoscopy procedures. The highest cost provider, I think their costs over here are about $3,500 compared to $1,500, so more than double. Not such a strong correlation for this. Their PAC rates are low generally for this procedure, but not a strong correlation here, unlike what we saw for diabetes and gallbladder. Instead, what we found when we dug into the data, and you can do this, I didn't do it for your data, but I did it on another data set that I had, and I think this holds true for a lot of states, that the provider cost differentials for the colonoscopy are more related to different utilization choices. So the choice about what anesthesia type is used, or choices about doing a double procedure, an endoscopy always with the colonoscopy. So, this is something where the cost factor or the utilization factor may weigh more heavily than a PAC rate. So one thing that we've done, one way to look at these measures to incent sort of value-based purchasing, to give weight to both the quality and the cost, is demonstrated here in this hypothetical example. Here we're looking at an episode of total knee replacement, 3 different provider groups. The costs $18,500 up to $25,000, and the idea being that each provider team here, surgical facility team together, can improve their standing by increasing the quality score and decreasing the episode price, provided that they meet a certain quality threshold. So we create this value index, if you will. The lower the number there on the value index, the more high value that provider. So high value in terms of lower cost with higher quality. We create that value index really just based off the episode price and the quality score. It's the episode price or the episode cost divided by the quality score. One could create different benefit designs around the co-payment based on that index. Here, the example here is just, the co-pay is compares the value index to the lowest value index, and comes up with a particular dollar amount based on what the costs of the episode were. So this is just sort of an example of using it in kind of a benefit design. Another example, in these slides, I was given permission by Blue Cross Blue Shield of North Carolina to use these slides as examples of how they're using the Prometheus methodology and the analysis methods to do specialty tiering. And so they're using both the quality measures, the PAC rates, as well as the cost measures, the efficiency measures. Here are the quality measures that they're using for the different specialists laid out. The ones that are highlighted in either yellow or in pink are those that are the Prometheus measures, simply the PAC rates. Those PAC rates are both a combination of the percentage of the dollars spent on PACs as well as the number of patients with a PAC. But you can see for OBGYN, for example, they're using the Prometheus PAC measures as well as certain standard screening checks. When they do this and they use this as well as the costs, what they've done recently is this is the percentage of doctors that are designated. They're using this in their Blues distinction network, so to have providers designated as a Blues distinction provider. This is the result. These are the doctors, the percentage of the doctors that are included in that network based on these measures. So cardiology, about 42% of the providers are included in that network, compared to orthopedics, about 65% of their providers are included in that Blues distinction network. And the way that they get that net designation, as I said, is through both an efficiency, a quality look, or a combination of both. So what these pie charts are showing you for each of those provider specialists is the reasons why providers were not designated. And so, for example, for OB/GYN, I would say it's about a little less than half of the providers that were designated were not designated due to quality measures. About 40%, 30% or so were based solely on efficiency measures, that's the cost measure. And then about a quarter were based on both measures together. They're still working on this, and they wanted me to make sure that I noted that there are some issues, like in the orthopedic practices, with some small low counts there that affect that, and that's why you see everything based on efficiency. So they're tweaking that, they're getting more data in to be able to really do that distinction a little bit better. That is it. This website here, this first one, HCI3, that's the Healthcare Incentives Improvement website. If you go on there and follow sort of the Prometheus paths all the way down, all of this information is very transparent. So for example, you would be able to see on there how the episodes come together, what services are determined to be included, what services would be excluded from an episode, and then what of those services would be determined to be typical versus packs of those episodes. So a lot of information up on that website that you can kind of go through.